Okay, we're going to talk about coagulation modifier drugs. Just as an overview, coagulation is a process of clot formation. Thrombosis versus embolus. So thrombosis or thrombus is a clot, whereas embolus is a moving clot. Tissue plasminogen activator dissolves clots. Coagulation cascade, we did the diagram. Hopefully you looked at the diagram before looking over these notes. Medications to alter coagulation. So you can have anticoagulants, which delays clot from forming. So these inhibit factors. Okay, so it's going to delay. I don't know why that's blue. It's going to delay the clot formation. Antiplatelet drugs, these inhibit platelet aggregation, so it prevents platelets from getting together. Okay, then you have hemorrhagic drugs. These alter the platelets. These usually prevent platelets from working, so prevents them from working. You have thrombolytic drugs. These break down clots that have already formed. Which is not to be confused with antifibrinolytic drugs, which promote coagulation in the blood, which is the last thing we'll talk about. So, anticoagulants. So your blood takes around a minute to go around your entire body, okay? So the purpose of anticoagulants is to slow down the coagulation process. So generally we want to prevent clots, right? So we're going to prevent clots because clots can cause an MI, can cause a stroke, can cause pulmonary embolisms, can cause DVTs, right? The mechanism of action is they inactivate factors, okay? Heparin, we already talked about. It's going to be 2, 10, and 9. So we're going to monitor the APTT. The low molecular weight heparin, enoxaparin, okay? It does affect these, but it greatly affects 10, so much that it is predictable. So this one's predictable with affecting 10, so it does not need any labs, whereas heparin is going to need labs. And then warfarin, okay? Warfarin is Coumadin. It is vitamin K dependent factors, so it's going to affect your 2, 10, 9, and 10, okay? And you're going to monitor your PT levels and your INR levels. We didn't really talk about INR in the diagram. INR is a ratio. It's a ratio of normal PT times, okay? So say if you had a normal PT, so a normal PT is like, say, 13 seconds, okay? And if a patient had a normal PT, their INR would be 1, because it's 1 times the normal ratio, okay, the normal time. Say they had an INR or a PT equal to 26, then that would be the same as like an INR equal to 2, because it's saying it's 2 times longer than the normal PT time. See what I mean? So if normal is 13 seconds, and then all of a sudden we get a PT of 26, that means our INR is 2. So some practitioners, they like INR. Some practitioners like a PT. They want to know exactly what the seconds are. So it's just preference. INR is really easy to remember. You don't have to remember any numbers. You just know, okay, a 2 means that it's 2 times longer than the average person to clot. Okay? So drugs that inhibit 2A or thrombin, they're listed there. And the drugs that inhibit 10, this is the first one in the common pathway, if you remember. It's right there, right at the Y. Okay? And so these drugs only affect one factor. So you don't need to do any labs with these. Okay, to look at it, just like like you have to do with heparin and warfarin, because you have to do PT and INR. Okay, so indications. Why do we need anticoagulants? Well, any condition where blood may be pulled or slowed down. So we're going to buy time. Gives us time to not start clotting. Okay, so if you're going to have conditions, would be like when you're sitting for a long time, when you're on bed rest. Okay, if you already had an MI or you have AFib, where your atria is going to sit there and it's going to quiver a little bit before it creates the P, okay, a good P to go to QRS. Okay, so it's going to kind of delay a little bit. When that happens, it's going to delay the blood process. We talked about the blood likes to circulate. It circulates every minute. It's completely circulated. So that's super fast. So anything that delays it even a little bit increases your chance of starting the clotting process and forming a clot. Okay? So it gives us time. It also prevents and the treatment of clots. So with the treatment, it doesn't dissolve clots, okay? Anticoagulants don't dissolve it, but it just prevents them from getting bigger, okay? That's really important, because there's only very specific things that actually dissolve a clot, and it's definitely not anticoagulants, okay? They just prevent them from getting bigger or dislodging, okay? So they'll be put on those. But the biggest thing is prevention with those, okay? So now we're going to talk about heparin, low molecular weight heparin. They're factor 10 inhibitors, okay? So these anticoagulants are given either sub-Q or IV, okay? Heparin, interestingly enough, comes from lungs or the GI mucosa of pigs. Just FYI, it's kind of interesting. So heparin can be given sub-Q or IV, okay? Adverse effects can be hemorrhage secondary to heparin overdose. So we can cause too much bleeding, right? Too much of a delay of that clotting process. So we wanted to monitor vital signs. We're going to be monitoring for bleeding. How do we know they're bleeding? We'll look for hypotension, an increase in heart rate, petechiae. We'll see bruising, hematomas. They're going to start having black tarry stools, okay? So if we see any of those, we're going to stop administration and we're going to give protamine, okay, which is the antidote. Oh my gosh, it will not let me write it. And of course, they're going to avoid aspirin because that's going to increase the risk. And we want to monitor their APTT, So we're going to monitor their APTT, yeah. And it should be around 30 to 40 seconds is normal. So therapeutic, if it's therapeutic, we want it delayed. So a therapeutic level would be around 60 to 80 seconds. Because we're buying time. We want it to be delayed. So therapeutic would be an abnormal lab. It'll look like it's too long. Okay? You can have heparin-induced thrombocytopenia, which is a sudden or gradual drop in platelets. So you want to stop if the platelets get below 100,000. We're going to stop it, okay? Because we know that can happen. Hypersensitivity reaction. This would be chills, fever, urticaria. So we want to administer a small dose prior to the first dose. So we want to give a small dose before the big dose. Okay. So toxicity and overdose, we'd administer protamine. Protamine binds heparin so that it can't do any damage. Okay. Adverse effects. Enoxaparin. Enoxaparin is only given sub-Q. Y'all know it is Lovenox. Okay. It can cause hemorrhage. It can cause neurological damage from a hematoma during spinal or epidural anesthesia. So you want to make sure you're assessing the insertion site in the epidural. And you want to monitor for a sensation or movement of the lower extremities. You want to make sure they're going okay. They're moving like they were. And you want to notify the provider of any findings if you see any. Thrombocytopenia, so we can monitor for platelets. So we're going to check platelets. And we're going to stop if below 100,000, just like we said before. Toxicity and overdose, we're going to administer protamine just like we would with heparin, but this is only for enoxaparin. Okay. So our contraindications, first, you never want to use two coagulation modifier drugs together, except for initiation of warfarin therapy. We'll do it. But in general, you should never be using two at the same time. Okay? So contraindications, IM injections. You don't want to use IM injections because this could cause large hematomas. That's why it's given sub-Q or IV. Okay? Low platelet counts, if they have thrombocytopenia, which would be less than 100,000, then we don't want to give it. During or following surgeries of the brain, the spine, an LP or regional anesthesia, because it increases the risk of a spinal or epidural hematoma. Caution with hemophilia, because they have a decrease in factors dissecting aneurysm, peptic ulcer disease, severe hypertension, hepatic or renal disease, and threatened abortion, all because these put you at increased risk of bleeding already. So we don't want to use those. Okay. Interactions, platelet aggregation inhibitors increase the risk of bleeding. So that would be like alcohol, aspirin, or NSAIDs. These all inhibit platelet aggregation, which is grouping together. Okay. Evaluation of effectiveness. Do we have a PTT that's with 60 to 80 seconds, which is what we want it to be? We want it delayed a little bit, but not too much. No development of further thrombi or emboli. Okay. Fondaparinux, which is the fondaparinux, which is the this one here, has a black box warning for put that black box for spinal hematomas. It does not like my M's. Okay. All right, nursing considerations with heparin baseline, and monitor your vital signs, your CBC, because that's going to tell you your platelets, your hemoglobin, hematocrit. With deep sub-Q, administer in units. You're using a 23-26 gauge needle. Make sure you read the label carefully. There are multiple concentrations of heparin available. You want to check the dose with another nurse. You want to administer 2 inches from the umbilicus, super important. You don't want to rub it. Oh, goodness. I don't know what happened with that. Make sure you don't aspirate, don't rub it. No, I can't spell. Don't rub the site. That's going to cause more bruising. Make sure you rotate sites. With a continuous IV, you're going to use an infusion pump because you need to be very exact in how much they're getting and how fast they're getting it. We want to monitor their PTT every 4 to 6 hours until appropriate dose, which would be a therapeutic. So once we have a therapeutic response. So we're going to be checking it till we get there. Because different people respond to the medications differently, so we want to make sure that we're right where we need to be. And make sure you check your doses with another nurse. So nursing considerations with enoxaparin and factor 10A inhibitor. Sub-Q injections, use the 25 to 26 gauge needle. Make sure you're rotating sites 2 inches from the umbilicus. You don't want to expel the air bubble so that you give all the medicine, okay? Don't aspirate because this could cause tissue damage, and don't rub the site after injection because it will cause additional bruising. Patient teaching with heparin, enoxaparin, and factor 10A inhibitor. We want to monitor for indications of bleeding. They're listed there. Make sure you know those. Avoid using over-the-counter NSAIDs, aspirin, or meds containing salicylates. This is because they increase the risk of bleeding. Okay. Use an electric razor for shaving and brush teeth with a soft toothbrush because these will decrease the chance of bleeding. In fact, if they will use these and if they still see bleeding, it may be an indicator that they have too much medication on board. So now we're going to talk about warfarin. Warfarin has a very long half-life. Its half-life is around 12 hours to 3 days, depending on how you metabolize it, okay? So it can take a really long time to get out of your system, but also takes a really long time to get a steady state in your system. So it can take about around 7 days or more to get a steady state, which means that's how long it takes also to get out of your system. Which is why when patients are on warfarin at home, when they get to the hospital, we switch them over to enoxaparin because it is a much shorter half-life. If anything has to happen, any procedures or whatever, they can just stop the enoxaparin and go ahead and have that procedure. Whereas if we kept them on warfarin, they would have to be off of it for quite a while for them to be able to have the procedure. So mechanism of action, it binds vitamin K, so it can't be used to synthesize vitamin K dependent factors. So that's the factor 7, 9, 10, and 2. Adverse effects, hemorrhage, so we want to monitor vital signs and observe for bleeding. Hepatitis, because we're affecting the liver, okay? So we want to monitor our liver enzymes, and we monitor for jaundice, okay? Because that would tell us that we're affecting the liver too much, right? Toxicity and overdose, we want to DC, so we want to stop it and give vitamin K. When you're giving vitamin K, you want to administer it slowly in small diluted doses. This helps to decrease the risk of anaphylaxis. And also by giving vitamin K, we're allowing the synthesis, we're giving liver the building blocks to produce those vitamin K dependent factors. So contraindications is a pregnancy category 10 or X, which means it absolutely do not give it. It will cause teratogenic effects. It can cause thrombocytopenia. You don't want to give it during or following surgeries, certain surgeries listed there. If they already have a vitamin K deficiency, which is common with liver disorder or alcohol abuse, you want to use caution with hemophilia, dissecting aneurysms, peptic ulcers, severe hypertension, and threatened abortion, because these are already at risk for increased bleeding, okay? So we want to be careful with those, okay? Now, when you give when you stop warfarin, it will take about 36 to 72 hours before the liver can start synthesizing the clotting factors again, just so you know that. Giving vitamin K in a high dose IV will reverse the anticoagulation that Coumadin or warfarin caused within about 6 hours. So it takes about 6 hours for this to work. So about 6 hours for vitamin K to work. So that's a pretty long time. So they're going to be at increased risk until that vitamin K really kicks in. So interactions, medications that increase the effects are acetaminophen, aspirin, heparin, glucocorticoids, sulfonamides, and cephalosporins. Decreased effects of warfarin would be phenobarbital, carbamazepine, phenytoin, oral contraceptives, and vitamin K. So we need to be careful about eating foods that are high in vitamin K. It's okay to eat foods that are high in vitamin K as long as they're consistent with eating those foods. They just need a consistent amount of vitamin K that they're eating every day, because if they suddenly drop the amount of vitamin K that they're taking in through their diet, then Coumadin is going to have, or warfarin is going to have more of an anticoagulation effect, because you're not taking it into your diet. The liver doesn't have enough because you're not taking it into the diet, and whatever you are taking in, warfarin's taking, binding, so it's preventing the absorption. Whereas, and then the opposite scale, if you take a lot of vitamin K one day, say you're eating a bunch, and then the warfarin's not going to be as effective because it can only decrease absorption so much. You're going to have a lot more vitamin K available in your system for the liver to produce those factors. Okay? So nursing considerations, a baseline and monitor your vital signs, your CBC, your your prothrombin time should be around 18 to 24 seconds, which is longer than normal. Remember, normal is around 13. And INR around 2 to 3. So let's put this down here. So PT around 18 to 24 seconds, which puts you at an INR around 2 to 3. And you always want to hold it if it's above therapeutic levels. And remember, therapeutic levels are going to put you, it's going to be a longer than normal. It's not going to be within normal limits. It's going to be higher. It's going to be prolonged because that's the purpose of the drug, okay? So it won't be what a normal PT time is because a normal PT is 13, okay? A normal INR is 1, okay? But a therapeutic, if they're on warfarin, PT is 18 to 24 seconds. And a therapeutic INR is around 2 to 3 times, okay, the normal clotting time, which is what that tells us. But if it's above these times, then we want to hold it, okay? So patient teaching, they need to administer at the same time each day. So how it works with the ingestion of food should be consistent. Monitor the PT and the INR levels. Monitor for signs and symptoms of bleeding. Make sure you know those. Avoid over-the-counter meds that have aspirin, salicylates, or acetaminophen in them. Avoid alcohol. That's going to further increase your risk for bleeding. Avoid thrombi development. So no tight clothing. Don't sit for a long period of time. Elevate and move the legs when you're sitting. Wear a medical alert bracelet that lets anybody know that you're on warfarin. They need to use an electric razor and a soft toothbrush to prevent bleeding. Consistent amount of foods high in vitamin K. These are like, how did that do that? This would be like green leafy vegetables. I'm sure you've heard these. Cabbage, broccoli, let's see, Brussels sprouts, mayo, and like mayonnaise, and then canola and soybean. So those are things that you'd want to. So cranberry juice, I don't have that on here. So cranberry can also increase effects of warfarin. Okay. Okay, remember that platelets go to the site of injury and they release the ADP, prothrombin, thromboxane A, and prostaglandin, okay, which causes these things to happen. So it attracts more platelets, causes vasoconstriction, stimulates the clotting cascade, the intrinsic pathway, remember. So the mechanism of action, they all prevent platelet aggregation and or stimulation. Thromboxane inhibitor is aspirin. It prevents platelet aggregation. Erase that. Hold on. So it prevents platelet aggregation and vasoconstriction. The vasodilator platelet aggregate inhibitors, they inhibit platelet aggregation. ADP inhibitor, all of these are all gonna prevent or inhibit platelet aggregation. Okay. So your antiplatelet drugs, indications, prevention of clot formation. So why would we want to prevent clot formation if after MI, to prevent another MI from happening, to prevent the first MI from happening, to prevent stroke, a TIA, which is a transient ischemic stroke, acute coronary syndrome, and intermittent claudication. Those would be reasons to be on antiplatelet drugs. So adverse effects is that they increase the risk of bleeding, right? So aspirin, you can have GI or hemorrhagic GI issues, which would be like nausea, vomiting, GERD. They can use a proton pump inhibitor, a PPI, if they want to help with that. It can cause hemorrhagic stroke. So because of this potential, they need to report any weakness, dizziness, or headache. The prolonged bleeding time, okay, it's going to could potentially cause GI bleed, thrombocytopenia, so we want to monitor for bleeding. So monitor for bleeding. And it can also cause tinnitus. So we want to monitor for any hearing loss. We need to stop the dose if it occurs. So abciximab causes hypotension, bradycardia, so we want to monitor blood pressure and heart rate. Prolonged bleeding time and GI bleed, thrombocytopenia, so again monitor for signs and symptoms of bleeding. Bleeding from any cardiac cath site, so we want to monitor the site and hold pressure to the site. Clopidogrel, we want to monitor for prolonged bleeding time, GI bleeding, and thrombocytopenia, so monitor for any signs and symptoms of bleeding. GI, it can cause diarrhea, pain, or GERD, so want to be aware of those. Pentoxifylline can cause GI symptoms, so this would be like nausea, vomiting, GERD, things like that. So antiplatelet drugs, contraindications, really it's going to be any bleeding disorders, any situations that put them at risk for bleeding disorders, or if they're already at risk for bleeding, so or any coagulation issues. So aspirin, if they have any bleeding disorders, thrombocytopenia. You don't want to give to children under 18 years old because of the risk of Rye syndrome, and we'll talk about this in peds. But Rye syndrome, my goodness, this is just awful. Hold on. Rye syndrome affects children recovering from a virus usually, and is given aspirin. So there's a connection between having a virus recently and having aspirin. And they think that the aspirin may trigger the Rye syndrome. But anyway, so Rye syndrome causes swelling in the liver and the brain. It can cause permanent brain damage or even death. So it's really serious. We want to caution aspirin use in people who have peptic ulcers, have severe kidney or hepatic disease, or with older adults. With abciximab, we want to monitor for bleeding disorders, thrombocytopenia, recent strokes, aneurysm, uncontrolled hypertension, any recent major surgery. Caution in use with peptic ulcer disease, severe kidney or hepatic disease. Clopidogrel, bleeding disorders, peptic ulcer, thrombocytopenia, intracranial bleeds. And with pentoxifylline, we want to contraindication with bleeding disorders, retinal or cerebral bleeds. So interactions, any other drugs that enhance bleeding, for instance, warfarin, NSAIDs, heparin, thrombolytics, antiplatelet drugs, those are going to have interactions. It's going to increase the effects. Aspirin specifically, beta blockers are going to decrease the antihypertensive effects of beta blockers, so we want to monitor the blood pressure. With corticosteroids, it can increase the GI effects of aspirin because corticosteroids also have can cause GI adverse effects. So if you give those and aspirin, it can increase the GI effects. So we want to monitor for any coffee ground emesis, black tarry stools that would indicate a GI bleed. Okay. With caffeine, we want to it will increase the absorption of aspirin. So it will increase the risk for aspirin toxicity if you have aspirin and caffeine. So aspirin toxicity, we'll talk about that. Signs and symptoms of aspirin toxicity. They are tinnitus, hyperventilation, vomiting, and nausea. Okay, so make sure you know those because it's super important. Okay. Clopidogrel, proton pump inhibitors will decrease the effects of aspirin. Oh, I had that there. Pentoxifylline, increased levels of theophylline. So we want to monitor theophylline levels. So with patient teaching, with aspirin, they should be on a low dose, and it's used for stroke and MI prevention. However, they're going to take a higher dose, 325 milligrams, if they've had, or during an MI, or if they had an MI. Use enteric-coated tabs. This helps to prevent GI upset and bleeding because the medication will not dissolve in the stomach. It will wait until a more alkaline state to dissolve. If you guys remember that about enteric-coated tablets. Report any signs and symptoms of stroke. ADP inhibitors, you want to stop before any elective surgery. Arterial vasodilators, you want to take with food. GI upset, because it can cause GI upset, so that will help with that. And you don't want to crush or chew the oral medications. Nursing considerations, you want to monitor bleeding times. You want to monitor for signs and symptoms of bleeding. Monitor for any adverse effects. With aspirin, you want to make sure there's any allergy to NSAIDs because there can be a cross reactivity. Also, you don't want to give it to patients that are under 18 because of the potential for Rice syndrome. Clopidogrel, remember the black box warning. Certain people may be unable to metabolize it to the medication to an active form, which will increase their risk for cardiovascular events. So, super important that they know that black box warning and what it indicates. Direct factor 10A inhibitors. So mechanism of action, it directly inhibits factor 10, so it's going to delay coagulation. It's used with AFib, DVT prevention, pulmonary embolism prevention, and stroke can be used for embolism prophylaxis. Adverse effects, it can cause bleeding in the GI, GU, cranial, retinal, and epidural. So if they're given it, we need to delay removing the epidural cath for 18 hours. We need to monitor H&H, and we want to monitor for signs and symptoms of bleeding. Okay. It can cause elevated liver enzymes, so we need to monitor their AST and ALT and report any elevated labs to the provider. Contraindications would be active bleeding, because this is just going to make it worse. Any severe kidney or liver impairment. Use caution in patients that are already on anticoagulants or on antiplatelet medications, because these will put them at increased risk for bleeding. So interactions, increased bleeding risk with these meds. Decreased levels of rivaroxaban. With those meds, the rifampin and phenytoin, St. John's wort. Nursing considerations to report any signs and symptoms of bleeding, which would be like bruising, headache, eye pain. Monitor the hemoglobin and hematocrit, liver and kidney function. Patient teaching, administer the same time each day. This helps to be consistent in your blood, a consistent steady state in your blood. Embolism prevention, we want to administer with the evening meal. So direct thrombin inhibitors, mechanism of action, they directly inhibit thrombin, which prevents thrombus from developing, so it delays the coagulation process. Adverse effects is bleeding. Feel like a broken record here. So we want to monitor for signs and symptoms of bleeding and vital signs. Can cause GI irritation, so nausea, vomiting, GERD, ulcer formations. So they need to take it with food, and they can take it with a proton pump inhibitor or H2 antagonist if they want to help with that. Contraindications, if they have active bleeding, caution in patients that have liver and kidney impairment, and the interactions, increased risk of bleeding with thrombolytics, anticoagulants, will decrease levels of rifampin. Rifampin is used with tuberculosis. So, nursing considerations, we want to stop the heparin and check the PTT before starting these, because heparin also inactivates thrombin. With IV, those are the IV doses, so the medications that are IV are there, the PO medications, and then the deep sub-Q medications. So these are just the different forms of the meds and then their names here. Patient teaching, do not crush or chew. Container must be used within 30 days. That means that if they don't have, even if it's not completely used up, they need to get a new one in 30 days. So Alteplase, this is a thrombolytic drug. So it is used for a clot that significantly interferes with the blood flow. So it could potentially cause ischemic stroke or after an MI. So remember, coagulation system forms a clot. Fibrinolytic system dissolves a clot. It's a several-day process to break down the clot. So the mechanism of action of Alteplase is to open the clogged artery very rapidly. So it can also be used for clogged central lines. So it activates the conversion of plasminogen to plasmin, which breaks down the thrombus. So this breaks down thrombus. Okay. Recombinant DNA is created, recombinant DNA is used to create tissue plasmin activator. So it's extremely expensive because it's made through recombinant DNA. Fibrin clot specific, so it does not cause a systemic thrombolytic state. It works directly on the plasminogen only. Adverse effects, has a very short half-life. Its half-life is around 5 minutes. Bleeding, of course, is going to be an adverse effect. It could be internal, intracranial, superficial, can be all over, depending on where you put it. Can induce cardiac dysrhythmias if it thins the blood too much. Interactions, increased bleeding if given with other drugs that affect coagulation or platelet function. Contraindications, concurrent use of other clot-altering drugs. So nursing considerations, close monitoring because we are breaking up clots. So super, super important. Limit venipuncture injections because it'll cause bleeding. You want to hold direct pressure for 30 minutes until the bleeding stops. Pressure dressings to recent wounds. You want to monitor PT, PTT, and H&H. Monitor for changes in vital signs, level of consciousness, and weakness, because it could mean that they have hypovolemia. So these would be signs and symptoms of hypovolemia, and we would want to notify the provider if any of these changes occur. You don't want to mix with any other meds in the IV, flush with heparin, or give aspirin to decrease the risk of rethrombosis, because remember it has a 5-minute half-life. You want to stop if bleeding occurs, administer with a PPI, proton pump inhibitor, to prevent any GI bleeding. Evaluation of effectiveness, how do we know it's working? Because there's lysis of the thrombus, restoration of circulation. If the thrombus was blocking circulation, then we'd have good circulation back to that area, would be our goal. Antifibrinolytics, hemostatic drugs, they prevent lysis of fibrin, so they promote clot formation. So all this stuff has kind of been preventing clot formation or breaking down the clot. This is actually promoting clot formation. These are the list of antifibrinolytics here. It can be used topically. Surgical procedures, surgeons can use it to stop bleeding during surgical procedures. Hemophilia drugs, factor R, 7, 8, and 9. It can provide the missing factors, okay? So, mechanism of action, it inhibits the breakdown of fibrin, so the clot stays longer. Desmopressin in high doses can cause an increase in platelet aggregation and clot formation. Indications, it prevents the prevention or treatment of excessive bleeding. Contraindications, if they have DIC, it just means that the coagulation process is overactive. It forms lots of little clots, quickly depletes the factors, and causes you to bleed out. So, more hemostatic drugs, so they promote clot formation. So, adverse effects, it can cause a thrombolytic event, which would be like a stroke, an MI, interactions, they're listed here. I'm not going to read them to you. With desmopressin, in high doses, it's similar to antidiuretic hormone, which is used for diabetes insipidus when they don't make enough antidiuretic hormone. Okay. Nasal spray can be used for nocturnal enuresis. The antidiuretic hormone, you may remember, tells the kidneys to keep water. So assessment, we're going to assess for any allergies, their past and present medical history, exercise tolerance. We need a baseline because we want to monitor for weakness and bleeding, okay, which will indicate bleeding. So we need to know, how are you doing so far? Like, how are you normally? And then, so if they start to notice that they're weaker, that could indicate that they're bleeding. So previous treatments may be contraindicated. So we need to make sure, what have they done before? Vital signs, weight, height, diet, heart rhythm. We need a baseline and monitor. Risk factors for clot development. This would be like immobility, dehydration. Write those down. Dehydration. All these increase your risk for clot formation. Smoking, CHF, obesity, and coronary artery disease. Okay, signs and symptoms of thrombophlebitis. These would be like edema. Let's put them here. Let's see. Edema, pain, warmth, in the area, redness, and this is directly over the vessel. Okay. With a PE, a pulmonary embolism, you would have chest pain, dyspnea, you could have cough, tachycardia, and decreased O2 levels. Okay. So we're going to assess the skin, the mucous membranes, gums, the urine, stool for any evidence of bleeding. You're going to check your labs. Puncture wounds, you're going to assess your puncture wounds for any bleeding and your IV sites, etc. Fondoparinox, we're going to assess renal function. So nursing considerations, avoid invasive procedures. So with thrombolytics, we have increased destruction of clots. So we want to avoid invasive procedures. We don't want to use with any anticoagulants and antiplatelets. We're going to monitor for signs and symptoms of bleeding. This is signs and symptoms of bleeding. We'll want to report pink, red, or cloudy urine, because again, could be urine, could be bleeding. Black tarry stools, abdominal or chest pain, dizziness, severe headache, because these are internal bleeding. That's not as easy to see. Monitor the labs with antithrombolytics. Remember, these stop bleeding. These cause a stop bleeding. We want to report immediately any changes in motor function, motor strength, or level of consciousness, because it could be a stroke, because it can cause clots, or it can make clots last longer, so it could cause those things. We want to monitor for heart rate, blood pressure, quality, and strength of pulses, because we're checking for circulation, perfusion, make sure that we're still perfusing adequately. So early signs and symptoms of overdose of any anticoagulant are bleeding gums, unexplained nosebleeds or bruising, heavier than usual menstrual bleeding. We want to make sure that we're watch all puncture wounds. Indications of internal bleeding, they're listed there. Make sure you know these, okay? And then the labs that you're checking, along with liver and renal function labs. So patient-centered teaching, educate the need for the drug. Why are they on it? Patients are more likely to take the drug if they understand why they're on it. They need to take all the drugs as prescribed, so they need to take them at the same time, okay? Same time every day, so that they achieve a steady state. Super important, okay? Regular follow-up appointments are important because we need to make sure that their levels are therapeutic, okay? They need to wear a medical ID bracelet. They need to report any unusual bleeding from anywhere. So like from in their urine, in their stool, when they cough, okay? Anytime they have bleeding from anywhere, okay? Severe headache, they have blurred vision, vomiting, blood, dizziness, fainting, fever, muscular or limb weakness, and rash, okay? With warfarin, they need a consistent diet of vitamin K rich foods. Just remember, it's consistent, so they can have vitamin rich foods. It just needs to be pretty consistent amount of vitamin K with every day, okay? Avoid cranberry juice, alcohol, and many herbal products because they can either increase or decrease the effects of warfarin. With dabigatran, the bottle must be kept tightly closed and used within 30 days. With clot preventive measures, these are things that all help prevent clots from forming. So no tight clothing, crossing their legs, prolonged sitting on the bed or bed rest, walking around every 1 to 2 hours on long car rides are good to help prevent that. So with cranberry juice and alcohol, these will increase the effects of warfarin. So herbals that interact with coagulation modifiers, capsaicin, red pepper, feverfew, garlic, ginger, ginkgo, and St. John's wort. They need to consult with a provider before taking any herbals or over-the-counter medications. They need to report decreased urinary output, ringing in the ears, which is tinnitus, swelling of their feet, ankles, legs, need dark urine or clay-colored stools, abdominal pain, rash, or blurred vision.